Okay, so where are we? I think we're officially halfway through the semester. Yay. All right. So the change I made just deals with the order of the next two chapters, basically the last two chapters in this unit, the muscular tissue and muscular system. So all of the other systems that we deal with, we do the tissue and then the system. So like the bone tissue and then the skeletal system. For some reason in the textbook that's flipped, and they have the muscular system, learning the muscles before we talk about the tissue. I think that's a little bit weird, so I flipped it, and we're going to do chapter 11 before we do chapter 10. So I fixed that on the schedule on Canvas on the homepage, and that means the chapter outlines are flipped as well. If you've already done the chapter 10 outline, which is now not due for a little bit longer, that's fine. You can submit that. I basically won't count either of them as late if you're off by a little bit. So don't worry too much about that. Just make sure to get both of them in by by the 29th of March, which is when the second one would be due, that chapter 10. It'll be helpful if you haven't done chapter 10 yet, just skip over that and do chapter 11 first and then come back to chapter 10. So we'll do muscular tissue and then the muscular system. So again, probably doesn't make all that much of a difference to you. I changed the assignment due date in Canvas as well. So on your to-do list, it should show chapter 11 is due first. I think this coming Monday before chapter 10. So just FYI, a minor change, but wanted to let you know about that so you know what to expect. One other aspect I wanted to talk about is your disease video project. So that video is due next Friday, March 26th. Is that the right date? Yeah, March 26th. So here we have, under the assignments, you can click on that assignment, the disease presentation video, and it'll give you details on what you need to do. This is just the same information that you've already seen before. But I wanted to remind you that you're going to record the video as a group. You can use whatever platform you want. I said Zoom just because it's easiest, or I think it's easiest, and everyone kind of knows it by now. But you can record it some other way if you want to. It doesn't really matter to me as long as you can upload it to YouTube, and then you post the YouTube link to a discussion board in Canvas. So you won't actually submit anything to this assignment, like the assignment Dropbox on Canvas. It's just here to give you the details and to populate the grade book essentially. So here I've said you're going to post it to a discussion board that I created. I think I created it yesterday, called Disease Videos. So I'll show you where that's at in just a second, but just a reminder, this is the information you should include. That's the information you kind of started getting together in your outline, right? It should be about 8 to 10 minutes. You'll record it, upload it to YouTube, and then if you go to discussions, you'll see one discussion board. Very straightforward, and this is where you'll post your YouTube link. You can make it so only people who have the link can watch it, or you can make it public. It doesn't really matter to me, but at least make it so people who click on the link can see it, right? That's all you need to do. You don't need to create any explanation in the discussion board. Just post, you might want to put the title or something, just post the link to your YouTube video. So that will have to be done. So that link will have to be up here on the discussion board by next Friday at 11:59 p.m. So you have a week and a half to get that done. Let me know if you have any questions or are kind of lost in how to do it, but just a simple PowerPoint presentation or Google Slides or whatever you want to use, along with your voices. That's all I really need. Any questions about that? Good, okay. Let's see, video reminder. Okay, I think I covered everything that I wanted to before jumping back into the joints chapter. So let's pull that up. So we were talking about all the different movements and terms for movements, right? We got through a lot of them. I stopped at the supination, pronation slide. So all these different movements, they all have different names. So there's kind of a lot of vocabulary in this chapter in general, particularly dealing with the movements. So we're just going to continue on here. I'll probably have to finish it up on Friday, and then we'll get into the muscle tissue as well, muscle tissue chapter. Okay. Here we go. So supination and pronation, I've mentioned the terms a few times. These are mostly just dealing with movements of the forearm. You can supinate and pronate your foot as well. I'm not going to talk about that. That's a very complicated kind of multi-axial movement. So in order to simplify things, we're just going to talk about the idea of supination and pronation in relation to the forearm. Supination is where your palms are facing forward. So if you're standing with your hands down, your palms are facing forward, in anatomical position, or if you have your hands up, your palms are facing up. So the easiest way to remember this is it's as if you're holding a bowl of soup. That's supination. So soup, supination. The other one would be pronation, where your palms are facing down or backwards. And what happens here is the radius and the ulna actually cross over each other. So in the supine position, with your palms facing forward or up, your radius and your ulna are parallel to each other. When you pronate your palm or your forearm, those two bones cross over each other. And the radius actually at the head of the radius up near the elbow rotates around the ulna. So it's then on the other side of the ulna. So you have an X in your forearm of your bones when your palm is facing down or backwards. That's pronation. And the images on the next slide might help explain that a little bit better. But it's the radius that moves. The ulna stays stationary. The radius is what rotates around. The head of the radius rotates around at the lower part of the elbow joint. So yeah, here if we look at the supine position versus the pronated position, you can see the parallel radius and ulna. And then with the hand flipped over, you have the radius actually now on the other side of the ulna. So for you guys on Zoom, sorry. You have the, here we go. Get that out of the way. You have the radius actually now on the opposite side. It rotated around. So it kind of rotated around the ulna to the other side. So you have an X. So that's supination and pronation. Again, really just forearm movements for our purposes. I have a slide that I hid in here, but it's available if you download the PowerPoint from Canvas. You can look at what supination and pronation of the foot is if you want to. You can unhide that slide and look at it. So if you're curious about that. All right. There are a few categories of special movements that deal with, well, that was specifically the forearm. So these are more kind of special movements that deal with specific parts of the body. So this slide is about obviously the head and the trunk. So when your head and trunk move, it may not be obvious as to whether it's flexing or extending the body. So when we look at flexion, talking about the head, so the head or the entire trunk, Flexion is going to be bending forward. So the angle here is decreased, right? So the front angle of the body is decreased, that makes it flexion. Same with the head, if you bend your head forward, that's flexion of the neck, and that'll come into play when we learn the muscles of the neck area. So there will be flexors and extensors kind of throughout the body, but flexing and extending the head sounds a little strange. So just remember, flexion is when you're bending the head forward, it's decreasing the angle between your body and your head, basically the angle of your neck. Extension would be the opposite, just straightening back up. You can hyperextend your trunk as well as your head, and that's just bending backward. So now the angle at the front of the body is greater than 180 degrees, so that would be a hyperextension. And same if you tilt your head backwards, that's hyperextension of the neck. Lateral flexion, pretty straightforward. You're just moving sideways. So moving from one side to the other, or your head moving towards one shoulder or the other. That's lateral flexion. Okay. Now, specifically with the hand, our hands are pretty important. We do a lot with them, so we have some specific terminology dealing with how the fingers and the hands move. So you have two kinds of flexion in the wrist. You can think about it from the wrist perspective. So you have radial flexion, where your hand moves towards the radius, which is on the thumb side, right? So if you move your hand in towards the radius, that's radial flexion. The other way is ulnar flexion. So flexion towards the ulna, flexion towards the radius. And then you can also, we talked about abduction and adduction with mostly the arms or the legs. So abduction is when you move your arms away from the midline. You can do that with your fingers too, if you think of the midline of your hand. Abduction would be moving, basically spreading your fingers apart, moving your fingers away from the midline of the hand. Adduction is moving your fingers back to where they're right next to each other. So you can abduct and adduct your fingers as well. Okay. Those are the hand and digit terms. And then the foot. Down to the foot. Like I said, we're not going to talk about supination and pronation. These are involved in that. But these are kind of simpler movements, I think, easier to understand. So you have a couple types of flexion in your foot. You can dorsiflex your foot, so pull your toes basically up towards your shin. That's dorsiflexion. The dorsal side is the top side of your foot. So dorsal. Plantar flexion is pointing your toes downward. The plantar surface is the bottom of your foot. So plantar flexion. And then you can also evert or invert your foot, and that just deals with kind of side to side motion. So an inversion would be where the sole is turned medially or inward. So here, this is inversion. So turning the soles of your feet inward. Eversion, you're turning opposite, obviously. The soles of your feet go out towards the lateral part of your lateral angle of your body. Inversion and eversion come into play. A lot of times if people are having pain in their legs or hips, they may be walking more on the outside of their feet or the inside. So you may naturally kind of invert or evert your feet without knowing it. And that can cause some issues with alignment in your joints. So inversion and eversion can kind of be important when you're talking about gait analysis, if you're looking at how someone walks and if they're just generally experiencing pain. So when you combine all of these, that's what supination and pronation of the foot is, but it gets kind of complicated. So we're just going to stop there with the dorsi and plantar flexion, as well as inversion and eversion of the foot. And that wraps up all of the movement terms. So I know it's a lot of vocabulary. Hopefully those diagrams help. If you can't tell what those diagrams are showing, there's a lot online. I think all those are from your book, so you won't really find any additional ones in your book. But if you're confused about what any of those movements are, obviously feel free to ask me. But if you just want to kind of quickly figure it out, there's tons of information online about those different movements. All right, and for the last section of this chapter, we're going to be talking about some specific synovial joints that are really important from a healthcare perspective, basically the ones that get injured a lot or have issues with them. So what we're going to cover for the rest of this time is the jaw joint, jaw, shoulder, elbow, hip, knee, and ankle. So those often have some kind of, people will present with issues with those synovial joints, either an injury or just general pain. So these are some of the more complicated joints in the body and thus cause a lot of trouble to us. So from a healthcare standpoint, these are really important joints. So we'll talk about the anatomy of some of these, a little bit more detail about the anatomy, and then some of what can go wrong essentially with them. So first, the jaw joint. I won't spend a whole lot of time on this. But remember, joints are named based on the bones that are involved. So here, when you think about your jaw, we're talking about the point where it attaches. So where your mandible attaches to the temporal bone. So the temporal bone is up here, kind of around your ear. And the mandible is obviously the jaw. So where those two come together, that's the temporomandibular joint, or TMJ. It's a more complicated joint than we think of it typically as. It has elements of a condylar joint, so this kind of hemispherical head fitting into a depression. A hinge joint, because obviously your jaw hinges, right? So it moves in that one plane. And it also glides a little bit. So it can move a little bit side to side, so that makes it a little bit of a plane joint as well. So lots of different movements. We think of it just kind of being a hinge joint, but it's a little bit more complicated than that. So you guys may have heard of TMJ syndrome. A lot of times it's just called TMJ, but TMJ is technically the joint name. So TMJ syndrome is where you have basically clenching or some kind of misalignment with your teeth that causes pain initially in the jaw or head area and can radiate outwards from there. So a lot of people are affected by this. The estimate is 75 million Americans. I should have put the cause first. I don't know why I put the signs and symptoms, but the cause of the syndrome often is psychological tension, so just stress. If you clench your teeth when you're stressed, or at night if you clench and grind your teeth, that can cause TMJ syndrome. Or if your teeth are misaligned. So if your teeth aren't aligned properly, the upper and lower teeth, and you're chewing often, right? We eat a lot. Each time that you chew, it can kind of cause a little bit of pain and issue with the jaw, and over time that can build up. So the signs and symptoms of this can be a clicking of the jaw. If your jaw clicks, that means bone is kind of hitting bone, which is not necessarily a good thing, or hitting it in not a way that it's supposed to. You can get pain that radiates kind of starting in your jaw, but it can go downward into your neck and back. So the muscles that connect to your jaw oftentimes go further down into the upper back, or the pain can radiate upwards into your head and cause some pretty severe headaches. Vertigo and tinnitus, dizziness and ringing in the ears are also two symptoms that you might experience if you have TMJ syndrome. So our balance is controlled by the inner ear, and if you, obviously your temporomandibular joint is really close to your inner ear, so if you're putting a lot of pressure on that, it can cause issues with your balance, as well as just hearing that ringing in your ears. There's a lot of different treatments for it. Depends on what the ultimate cause is. If it's psychological, stress, then you can deal with it from a therapy standpoint. So psychological management, go see a therapist, deal with the stress, kind of the root of the problem, so you're not stressed, which is going to cause the TMJ syndrome. Physical therapy can help. So just learning how to not clench your jaw or move your jaw in the correct way. To deal with the symptoms, so not really the root cause, but you can use painkillers, analgesics, and anti-inflammatory drugs. If it's due to misalignment of teeth, just getting your teeth fixed can help. So realigning those upper and lower teeth can help. Okay, that's TMJ syndrome. That's all I'm going to talk about with the jaw, really. That's the main issue we deal with at the jaw joint. Into the shoulder. So the shoulder joint has two names. It can be called the glenohumeral joint or the humeroscapular joint. So glenohumeral comes from the fact that the humerus fits into the glenoid cavity of the scapula. So humerus fits into the glenoid cavity, or just humeroscapular more generally, the humerus articulates with the scapula. So it kind of has two names. This is the most freely mobile joint in the body. So you have a ton of range of motion with your shoulder, more than any other joint in your body. That range of motion is great, but it leads to lower stability. So your shoulder is not very stable. We'll talk about the rotator cuff when we get into the muscles, but there are tendons and muscles that essentially hold your shoulder in place. And I'll get into that a little bit more in just a second, but we'll talk about the specific muscles and tendons that do that when we get into the muscular system chapter. But you can see it's a pretty shallow cavity, the glenoid cavity. So all that's really holding it in place, it's not like two puzzle pieces like the head of the femur and the hip socket. Those fit together a lot better. There's a deeper indentation for the femur. Here is pretty shallow, so most of the work is done by these rotator cuff tendons. Shoulder dislocation is not uncommon. I probably don't have to say that it's very painful, but it can cause actually permanent damage. It depends on how severe or how often your shoulder becomes dislocated. So here you can see the normal setup of the humerus in the glenoid cavity. Dislocation is where that humerus, the head of the humerus, comes out of the glenoid cavity. And the inferior dislocation is usually the most common. So where you have the humerus actually moving down and out of the glenoid cavity. The reason for that is that the rotator cuff essentially protects the shoulder in all directions except that inferior position. So there's tendons and muscles holding your shoulder in from all three sides basically, but not that fourth side, the underneath in the inferior position. So usually when a shoulder gets dislocated, the person's arm is usually abducted, so it's out from the body, and then it experiences a blow from above, and that will shift the head of the humerus out of the glenoid cavity. It can potentially tear some of those tendons, which is the kind of permanent damage that I talk about. So if the tendons or muscles are torn or injured when that bone slips out of its socket, it can cause some much longer term damage. Children are especially prone to dislocation as their bodies are still developing, the tendons are still developing. So children will often experience, even without a whole lot of pressure, shoulder dislocation. All right, onto the elbow. The elbow is more complicated than we give it credit for. It actually has sort of 3 joints within it if you break it down. So the first 2 are here between the humerus and each of the bones in your forearm. So the humeroulnar humerus, and ulna, and then humeroradial, humerus, and radius. So we have 2 joints dealing with the humerus. So here you can see that we consider those kind of 2 separate joints. They're different bones coming together. That creates the hinge joint that we talk about and we usually think about with the elbow. In addition to those joints, there's really important bursa on the back side of the elbow called olecranon bursa. So your elbow is your olecranon. It's part of your ulna. And that just helps ease movement in that hinge joint. That can become inflamed. Bursitis is pretty common in the elbow area. So that deals with specifically those olecranon bursa. So that's the hinge aspect of the elbow. But we also have what I just talked about, the radius and the ulna, right? So they join together as well, and that's a pivot joint. So the radius pivots over the ulna, like I just described in that supination pronation example. So you do have a pivot joint within the elbow as well. So there's a lot of pieces to the elbow joint. You don't have to know these ligaments and everything. I just wanted to have that up there for you to reference if you were interested in learning a little bit more about the ligaments that are essentially holding your arm together. The elbow is also often dislocated in children. So children are prone to both shoulder and elbow dislocation. All right, I think that's all I have on the elbow. Yeah, moving on to the hip. The hip joint, pretty critical. As we move down into the lower reaches of the body, now we have obviously issues with movement, but these joints also support a lot of body weight. So they get a little bit stronger, so you get slightly less freedom of motion. That applies to the hip as well. So the coxal or hip joint is where the femur is fitting into that acetabulum of the hip. So the head of the femur fits into the acetabulum. It's a pretty deep socket. It's more stable than the shoulder. The acetabulum is a lot deeper than the glenoid cavity is. So those 2 pieces fit together a little bit more solidly. But like I said, you get slightly less range of motion. So you can't move your hip quite like you can move your shoulder. There's not as much of a range of motion. Something that helps to increase the depth of that, that hip socket is the acetabular labrum, which is just fibrocartilage that's inserted into the acetabulum. And that deepens the socket. So the head of the femur fits even more securely into the acetabulum. Ligaments. So you don't need to know which ligament is which, but do recognize their names here. So there's 3 main ligaments that are going to hold the femur essentially into the acetabulum. Those are, well, they all have femoral in them because they're attached to the femur, and then they're attached to the different bones of the hip. So the ilium, the ischium, and the pubis. So you have iliofemoral, ischiofemoral, and pubofemoral. So those are the 3 ligaments that are essentially holding your leg to the rest of your body. When you stand up, they actually twist a little bit, and that pulls the femur into the hip socket. So when you sit down, they untwist. When you stand up, that twists them and tightens that joint a little bit, pulling the femur into the hip socket so it's more secure. Differences between the male and female pelvis. I think most people know the female pelvis is typically wider than the male. So males have a more narrow pelvis. Females have a wider pelvis. Females also have a shallower, kind of, if you think about it as a shelf, they have a shallower pelvis. Males have a pretty deep one, so the bones go a little bit further up and down, basically, in a vertical plane in male pelvises than they do in females. That's because having a shallower pelvis kind of creates a shelf for the fetus to rest on during pregnancy. So it creates this nice little shelf. It's wide, it's shallow, helps support the weight of the fetus. And males obviously don't need that. Dislocation of the hip. So I said shoulder dislocation is really common. Hip dislocation, thankfully, is not. It fits, the two pieces fit together a lot better, a lot more securely. If someone does dislocate their hip, it can cause some pretty major long-term issues, like an adult. If an adult actually dislocates his or her hip, it can tear all kinds of stuff. There's really important arteries and veins down there that can be torn as well, which can cause some major internal bleeding. So hip dislocation as an adult is not a good thing. I mean, it's never a good thing. Infants, a lot of infants will have congenital hip dislocation. So they'll be born with an acetabulum that basically isn't deep enough to accept the head of the femur securely. So it's relatively easily fixable. The infant just has to wear a harness for 2 to 4 months to kind of position the legs in the correct way and help encourage the femur to fit into the acetabulum in the correct way. So it's very fixable. It's not common in infants, but it's more common in infants, thankfully, than it is in adults, and much more fixable at this stage as well. So hip dislocation, I think that's all I have on the hip joint. Moving down into the knee. So the knee, this is going to be the largest and the most complex synovial joint in the body. The technical name for it is the tibiofemoral joint. So it's the tibia joining with the femur. It's pretty much just a hinge joint like the elbow, but we can't forget about the patella. So the patella is the kneecap bone on top of the femur. So there's a joint there as well, the patellofemoral joint, and that's a gliding joint. So the patella kind of glides over the femur where it's actually attached. So you have a hinge joint primarily, but you have a little bit of a gliding joint if you're talking about the patellofemoral. The knee is also capable of slight rotation, so you don't want to rotate your knee too much. That's when you get injuries. And then the lateral gliding as well. So it can glide just a little bit. The tibia, the femur can glide a little bit on top of the tibia, a little bit side to side. It can rotate a little bit, but very, very small amounts before an injury occurs. So a lot of you have probably injured your knee in some way, and maybe not a lot of you, but some of you may have injured your knee in some way. The knees get injured a lot. It's not uncommon, so I'll talk a little bit about that as well. We'll talk about the anatomy of the knee joint in a little more detail than I have the other joints as well. So you don't need to know all the parts of this. I just wanted to provide these 4 figures for you. These are just different views of the knee. So you have the front of the knee, the back of the knee, a sagittal section, so if we cut down the middle and kind of looked at it from the side, and then a transverse view, so looking down into the top of the knee, you can see those menisci really well, which I'll talk about in just a minute. So those figures are mostly just for reference for you. I'll point out a few important pieces on the next few slides. All right, so an important part of the knee is that the joint capsule really only encloses the lateral, so the side and the posterior parts of the knee. The front is not enclosed in the joint capsule. Overall, the knee is stabilized by some ligaments, which I'll talk about. In addition to those ligaments, you have a few tendons and then the menisci, a couple tendons in the menisci. So in the front, you have the quadriceps tendon. Your quadriceps muscle is the front thigh muscle that you have. So the tendon that connects that muscle down to the lower leg is the tendon I'm talking about here. Semimembranosus, kind of the same, but on the back of the leg. Semimembranosus is a muscle. So the tendon of that muscle helps stabilize the back of the knee somewhat. And then those two menisci in the knee. So you have the lateral on the outside, medial on the inside. So you have these two kind of C-shaped menisci in the knee. I've talked about these articular cartilages and why they're important, kind of some of the purposes. Same idea here with the knee menisci. So you have the ability to absorb shock. So they're kind of like little mini pillows in your knee, kind of. They help absorb shock between the femur and the tibia. And they also keep your knee from rocking too much side to side. If you have too much rocking side to side, you're going to start tearing. That's when tearing of the ligaments essentially starts. So that kind of keeps the bones fitting together a little bit better, so you don't have so much tension on the ligaments. All right, so let's talk about some of the ligaments real quick. Looking at the back of the knee here, the popliteal or posterior region, you have a couple of ligaments that are actually outside the joint capsule. So they're on the outside of the knee, the lateral and the medial collateral ligaments. So if we're looking at the back here, this is going to be the lateral on the outside, lateral collateral ligament, and then medial. So right on either side of the knee there. They're mostly called lateral and medial. That's usually what you hear them referred to as. But they can also be called the fibular and the tibial because they're either on the fibia side or the tibial side. So medial would be tibia, lateral would be fibular. So LCL and MCL, I feel like I hear about the MCL a little bit more, that might get injured more frequently. But these are kind of stabilizing the knee from the outside perspective. And then at least one I'm sure you guys have heard of here, the interior, so the intracapsular ligaments. So within the knee, so we're talking about right in the middle here, you have the ACL and the PCL. I think most people have heard of the ACL, the anterior cruciate ligament. That gets injured a lot. A lot of people tear their ACLs. My husband tore his ACL and had to have surgery on it. I've had students who have had ACL tears. So the ACL is often injured. It's what prevents the hyperextension of the knee. So you don't want to overextend your knee, right? Hyperextension in some areas is fine. Overextension, hyperextension of the knee is what causes oftentimes an ACL tear. So these two are called cruciate ligaments because they cross each other. So cruciate means cross. So they are crossing each other within the capsule here. So here you have the ACL, here you have the PCL. PCL is the posterior cruciate ligament. It helps your femur stay on top of your tibia so they don't slide off each other. Very important. Okay, so ACL and PCL. Knee injuries. I mean, I'm not going to go into too much detail on this, but knees, like I said, often get injured. They're really vulnerable to horizontal stress. So if you get hit horizontally in the knee, not a good thing. or rotational stress. So if your femur is going one way and your tibia and fibula are going the other way, that's going to tear all kinds of stuff within the knee, menisci, ligaments, etc. So the most common injuries, like I said, the ACL typically, as well as the menisci can tear. Typically, surgery can repair these, but the healing time is longer because there's not a whole lot of blood flow to this area within the knee. So lower blood flow means less oxygen, fewer nutrients are coming in over a given time period, which makes the tissues recover a little bit more slowly. So here's just some images real quick. We'll run through these and then we'll be done. So here's the menisci. So you can see, rather than in diagrams, actually see them in an actual leg. So the two menisci here, lateral and medial. And then those outer ligaments, the medial and the lateral LCL and MCL on the outside of the knee there are highlighted. And then here are the cruciate ligaments on the inside of that joint capsule. So you have the anterior cruciate ligament. So here we're looking at the front of the knee, anterior. You can see the back of the knee, how it looks from there. And then the posterior cruciate ligament in the back of the knee. So crossing behind that ACL. Here you can see most of it in the posterior view. Okay, and then the ankle we'll get into and finish up on Friday. And then we'll start the muscle tissue chapter as well. So that's it for today. If you can bring your exams back up here before you leave, that would be great. And enjoy your day off tomorrow. Yay.